So welcome to the Spine Research Institute lecture series. So we are pleased to have with us today Professor Jack Stephens. Jack is a professor, clinical psychologist, and a professor of pediatrics at Nationwide Children's Hospital. He's also part of the College of Medicine here at The Ohio State University. And Jack and I had an opportunity to speak several weeks ago, a couple months ago now, where we got to know each other in a conference call. And he does some amazing work on basically behavioral psychology, which has got a lot of relevance to what we do here in terms of health as well as prevention of musculoskeletal disorders. So we got to talking and invited him to give a talk. Since then, I've learned that he's also a sleep expert for children. So I'm sure John's going to be asking you some questions. Yeah, and he was explaining to me that they've got some YouTube presentations that tell you everything you need to do about it. So, well, that's offline if you're going to talk about that. So anyways, welcome, Jack. Glad to have you, and please take it away.
So again, thank you so much for the invitation. It's great to be with all of you today. I want to actually start off by addressing what I think could be the elephant in the room. Why does a child psychologist want to talk with a group of people who probably focus largely, if not exclusively, on more adult health-related issues? So I always have to remind myself that in the United States, about 90% of healthcare and healthcare-related issues actually focus on adults, much more so than kids. So because of that, at this stage of my career, I'm really interested in those who have applications for adult and health and well-being. So I hope we'll have some opportunities that might inspire you to think about some potential collaborations as we talk about this moving forward. And I think one of the other things you're going to notice about me is that the examples I give to illustrate a lot of these concepts really come from the field of healthcare. So again, hopefully it'll really be really clear a little bit more about what these strategies are all about. But I also want to be cognizant of the audience that I'm talking to. And later in my presentation, you're going to see some examples of these strategies specifically used in an industrial setting to promote health and well-being. So just kind of hang in there as we hear about a lot of these things when it comes to healthcare purposes. Maybe a little bit more towards the end, you're going to find this is a little bit more directly relevant for some of the work that goes on here. And do I need to point here? There we go. All right. So here are my disclosures. One of them is directly relevant for today's presentation. So for 3 years, I had partial salary support from the Center for Disease Control and Prevention. I had been working with community health workers across the state of Ohio to encourage Ohio residents of all ages to get COVID-19 vaccinations and boosters. So I'm briefly going to talk about that vaccination work today. So because of that, I need to give this disclaimer. The views expressed in today's presentation represent only those of the speaker and do not necessarily reflect the policies of the CDC. So I want to start us off with this presentation with what I think is an inspirational quote. And I've used this quote dozens and dozens of times with different presentations that I've given with behavioral economics over the last 7 or so years. So this quote actually comes from a commentary that was published in the New England Journal of Medicine from 3 internal medicine physicians. So here's the quote. The final common pathway for the application of nearly every advance in medicine is human behavior. No matter how effective a drug, how protective a vaccine, or how targeted a therapy may be, a clinician usually has to prescribe it, and a patient accept it and use it as directed for to improve health. So this quote comes from 3 leaders of the United States' first healthcare system to have a formal behavioral economics team. This team was known as a nudge unit and was established back in 2016 at the University of Pennsylvania School of Medicine. So nudge units can focus on 2 different broad categories of interventions, some that are addressed towards patients and some that are addressed towards clinicians. On the patient side, what can be done to encourage patients to follow healthcare provider recommendations? On the clinician side, what can be done to encourage clinicians to follow evidence-based guidelines? Now, as often as I've used this quote, when I was preparing for this talk, I came across a quote that I found eerily familiar that actually comes from your director that was written 10 years earlier. So let's see this quote. I'll read it aloud. Thus, psychosocial factors should be considered in conjunction with physical adjustments to the workplace. One can develop the world's best engineering solutions to minimize back stress at work. However, if workers do not accept the change and use the intervention becomes useless. That was written 10 years earlier, but I think there's a lot of overlap that suggests that maybe we're going to have some really interesting discussions today. So let me give you a definition of behavioral economics. This is a field that features insights from both psychology and economics, and its goal is to improve decision-making, helping people make good decisions in the short run that are consistent with their long-term goals and priorities. Historically, a lot of the focus has to do with financial decisions. How can we encourage people to save more for retirement during their working years so they'll be more financially comfortable in their later years? How can we encourage people to cut back on their home energy usage so they'll save on their utility bills? But over the last several years, there's been more and more attention given to behavioral economics for health purposes. In fact, you may have some novel applications for behavioral economics that others have simply not considered before. That being said, I don't want to oversell the novelty of this approach. I think you're going to find that a lot of the strategies I talk about today very much overlap with the human factors framework, but I'm hoping at least some of the ideas I talk about today will be relatively novel for you. So when we talk about behavioral economics, the word that's most closely associated with this field is the word nudge. So let me give you an example of a nudge. A GPS device, a device that gives you instructions in terms of walking or driving to an unfamiliar place. So let's think about the characteristics of that device. First of all, it's going to give you brief yet firm instructions. It's not going to tell you 10 different ways in terms of getting from point A to point B. Most of the time, the information is accurate, not always, but most of the time it's accurate, but it's truly optional. So if I'm using my GPS device, I decide to drive a different route than the device recommends, it's not going to shut off my automobile. And at least the automated voice that comes from my device is respectful. So if I decide to drive a different route, that automated voice isn't going to come on and criticize me. It's not going to say, Jack, what are you doing? This is making no sense, right? So this is the essence behind nudging. You're certainly not neutral. You're trying to move people in a particular direction, but you respect the fact at the end of the day they have freedom and choice. And the idea of nudge comes from two different professors. Richard Thaler, who's been a University of Chicago Business School professor, who won the 27 Nobel Prize in economics, and Cass Sunstein, a Harvard Law School professor, who is perhaps the most widely cited legal scholar in the world. What's really exciting about behavioral economics is that when it comes to changing healthcare provider behavior, there have been a series of systematic reviews that have been conducted over the last few years. This is still a relatively new scientific field. And if you actually look at the dates that are in bold there, you're going to see that these are relatively new reviews. And you have 4 different systematic reviews suggesting, with different criteria, different investigative teams, that the type of strategies I talked about today can be useful for improving healthcare provider performance. We should take just a moment and talk about what behavioral economics is not. Behavioral economics is not the same as economic behavior. I'm going to definitely give some examples from the business world to illustrate certain concepts. But basically, I'm also going to spend a lot of time talking about how it's relevant for health and healthcare. Behavioral economics is not the same as mental health economics. Mental health economics is a completely separate field that looks at the financial aspects of psychiatric illness and psychiatric treatment. So mental health economics would address a question like, what is the lost productivity in the United States due to depression? I think you'll see the types of topics I talk about today far different from that. And even though economics is in the phrase BE, BE is not solely concerned about financial incentives. There is an entire branch of behavioral economics that has to do with the optimal design of rewards and penalties. That's not what I'm going to be focusing on today. I'm going to be focusing on other aspects of BE primarily. And I really like to do whatever possible to make sure that people feel like that this particular presentation has been tailored for them. So to try to do that, this is what I came up with. Because I'm presenting at the Spine Research Institute, I'm going to use SPINE as an acronym. So we're going to talk about 5 categories of nudging involving simplification through defaults, phrasing, images, norms, and employee input. And my guess is maybe those first and the last one are going to be things that you really resonate with and are pretty familiar with, maybe in different contexts. Maybe the ones in the middle may be a little bit more novel, but maybe you can give me feedback at the end to see if my assumption is correct. So the first one we're going to talk about is simplification. So in behavioral economics, the big thing we talk about is something called changing the default. So this refers to the automatic selection or the presetting. You go into a word processing program, a certain font size and a certain font type has been pre-selected for you, but you can easily change that. That's the default. So the classic example in behavioral economics has to do with retirement savings programs. So let's talk about the difference between opt-in versus opt-out. So under an opt-in basis, on an employee's first day, an employer may go to an employee and say, hey, we have this voluntary program. If you want to set aside 3 or 5% of your salary for this voluntary program, please take a couple minutes, complete some paperwork, turn that into human resources. That's the opt-in approach. The opt-out approach is a different approach. Under the opt-out approach, the employer would say on your first day, we as your employer have already pre-enrolled you in this voluntary program. But if you don't like that arrangement, you want to get much money as you can right away, you can easily disenroll. Just take a few minutes, complete some paperwork, turn that into human resources. And what was found is more employees were more likely to participate under the voluntary program under opt-out versus opt-in, with the justification being that people often need to save more for retirement. We want more people to participate in these voluntary programs. So the question becomes, why does that make a difference? Well, one reason is it may be an effort to switch from the default. We're all very busy people. If something has been prearranged for us in a particular way, we may go along with that arrangement. But it also may work for a different reason. It may signal a preferred pathway. So under this scenario, employees may be wondering, I don't know what I should be doing in terms of my long-term financial well-being. If my employer has pre-enrolled me in this voluntary program, maybe I should heed that wisdom. So let's give some examples of this that are relevant for healthcare. And I thought, again, since I'm talking at the Spine Research Institute, I'm trying to find relevant examples. So in this example, we're going to talk about spinal taps. And this was a study that was trying to increase the use of needles with atraumatic tips for lumbar punctures, for spinal taps. The article was titled, A Nudge Towards Better Lumbar Puncture Practice. So the idea is there's 2 different types of tips that can be used for a spinal tap, an atraumatic tip and a sharp tip. The atraumatic tip is less likely to cause a bad side effect afterwards, like a really bad headache, and can be used for the vast majority of spinal taps. So under the old default in this particular healthcare system, both the sharp tip and the atraumatic tip were readily available. They switched it. So under the new system, what they did is they made only the atraumatic tip readily available. So think about where everything is kind of stored in terms of cabinets and drawers and trays. It was really easy to find the atraumatic tip. It was more difficult to find the sharp tip. And this actually had more of an impact than actually training people more on how to actually use that atraumatic tip. The idea that just environmental placement of equipment can make a difference. One of my other favorite examples, trying to get visitors to use hand sanitizer when entering a healthcare facility. So what they did is they strategically placed the hand sanitizer dispenser stand right next to a security desk that people often have to stop by if they're going to be a visitor to a healthcare facility. If that hand sanitizer dispenser stand was just a few feet out of somebody's normal walking pathway, they were much less likely to use it than if it was very strategically placed, right? Again, kind of thinking about that interaction between equipment and the human to try to maximize that good outcome. One of the big things we talk about within healthcare is how do we manage the electronic medical record to try to nudge people towards desired behavior. So there's been a lot of interest over the last decade in trying to make sure that patients who are prescribed opioid medication get the least amount of medication possible. Because the longer that they're on these medicines, there's more opportunity for them to become addicted to them. And the more pills they have, there's more opportunity for those pills to be diverted to somebody else. So under an old default in an adult health system, whenever a prescriber would type in the name of an opioid, say oxycodone, there'd be different parameters about that prescription. And in the number of pills to be dispensed field, 30 would be auto-populated by the computer. But the clinician could adjust that upwards or downwards if they wanted to. They switched to a new default. The lower default was 12 pills that would pop up on the person's screen. And what they found is that this actually led to a decrease in the number of pills to be dispensed, which is what people ultimately want. But skeptics may say, if prescribers are just prescribing fewer pills, that doesn't make any sense because people are just going to call back asking for more pain medicine after surgery. That was not the case. There was no difference in opioid refill rate requests with the new default versus the old default that's suggesting 12 was often a sufficient number of pills. And you're going to notice that this study was actually published in JAMA Surgery. And a lot of people, if you think about a very prestigious journal like that, you're thinking about, well, the only thing JAMA Surgery would publish have to do with like surgical techniques or long-term surgical outcomes. I'm going to suggest to you that this was published in this particular journal because it's an opportunity that's relatively easy for other healthcare systems to adopt in terms of doing something that would be very consistent with their long-term goals and priorities. Another example within the electronic medical record. So in this study at the University of Pennsylvania Health System, they were trying to increase the likelihood that generic medication as opposed to a brand name medication would be prescribed. The idea being that a generic medication has the same overall active chemical ingredient, it should have the same overall biological effect, but costs much less to patients and insurers. So under the old opt-in system, if a prescriber wanted a generic medication to be prescribed, they would actually have to type that in directly into the EMR. They switched to an opt-out approach. So under the opt-out approach, there would be a spot where the clinician could type in the name of that medication. But then all of a sudden under that, there would be a little box that would appear that would read dispense as written. And basically the clinician would have to check that box in order for the brand name medication to be given. If the clinician typed in the brand name medication and didn't check that box, the computer would automatically assume the generic is absolutely fine and would send that through to the pharmacy. And this dramatically increased the generic prescribing rate from about 75% to 98%. It had much more impact than simply trying to encourage people to prescribe generic medication through continuing education. But you're going to notice it wasn't 100%. There were some times where people would actually click the box, and that wasn't random. There were situations where people would actually click the box, particularly for one type of thyroid medicine, where there was concerns that maybe the brand name and the generic wouldn't have the same overall effect. And there's actually a freely available podcast through the Freakonomics series entitled How to Save $32 Million in 1 Hour. Now, again, I don't want to oversell nudging. I'm not saying all nudges are this powerful. But basically, this was really an example at the University of Pennsylvania of a very powerful nudge that saved insurers as well as patients a lot of money. And this actually led to the University of Pennsylvania looking at these types of strategies for other types of applications. So let's just see if we have a chance for a little interaction here and see if we understand the difference between opt-in versus opt-out. I'll give you a couple examples. So let's say that we want to increase double gloving for certain types of surgery. So the rationale is that if clinicians wear 2 sets of gloves as opposed to a single set of gloves, this reduces unintentional contamination within the operating room environment. Remember, gloves can wear down. There are all these sharp instruments that are involved. You don't want people to kind of transmit blood between members of the surgical team and the person who's having the surgery, right? So under an opt-in approach, a surgical team member would have to request 2 sets of gloves from whoever is gloving the other members of the surgical team. Can anybody tell me what would be the opt-out approach? Any idea? Please. You could do that or just presume that everybody wants 2 sets of gloves. So whoever is gloving other members of the surgical team would just assume when you're coming through the door, the operating room, and it's time for you to do that, you want 2 sets of gloves. But remember, it's a nudge, it's not a mandate. So if you don't want 2 sets of gloves, you don't have to have that. Another example, increased use of instructions for certain pieces of medical equipment. So there's certain pieces of medical equipment that don't have to be used very often. And often what do we ask clinicians to do? Review a paper manual, or probably more likely these days to find an online manual to get those instructions. So that would be opt-in. Anybody have an idea what opt-out would be? This is probably a little less obvious. Would be where you would have the instructions right on the piece of equipment or right next to the piece of equipment. It doesn't mean somebody has to follow those instructions, but they'd be more likely to get them this way. So by now you probably have a sense, I'm a big fan of changing the default. I'm going to talk about a couple of situations where it has suboptimal or mixed results. So particularly with winter coming, and we're supposed to have colder temperatures actually over just the next few days. They were trying to figure out in this study how to decrease energy costs. And one of the things they did is they changed the default temperature setting on a thermostat in a room by 1 degree. They lowered it by 1 degree. So you may say, okay, maybe that's going to save a little bit of energy. Why don't we get more ambitious? Why don't we change it by 2 degrees? That actually was less successful because when you changed it by 2 degrees, the room felt cold and uncomfortable. People adjust the thermostat upwards. And I actually saw a recent example where an energy company, because remember, energy companies, according to the regulators, right, are supposed to help people be energy conscious and all that, not use as much energy. Saw where an energy company was encouraging people to change their default settings by 8 degrees. Now, I don't know about you and your home. If I changed it by 8 degrees, I would not feel comfortable. So you got to really wonder, were they really genuine in trying to help people be more energy conscious and all that? But the point is that if you get to the point where you're making people feel uncomfortable, changing the default may not work if you try to be more ambitious. Second example, this had to do with New York City taxi cab drivers. So imagine a situation where you're using your credit card in New York City and you see those tip screens that we all see all over the place, particularly if we're seeing this at a restaurant, where basically you may have some default tip suggestions as well as the opportunity to customize the tip down to the penny or provide no tip whatsoever. So under the old screen, customers would be shown these potential defaults, 15%, 20%, 25%. They switched it to higher defaults that you'd see on the screen, 20%, 25%, 30%. So the first result was good. By having those higher default tip suggestions, the cab drivers actually got higher average tips. It was nudging people to tip more. But it wasn't entirely successful. Look at that second result. The higher default tip suggestions were associated with more customers not tipping at all. Because some people were probably taken aback. They were like, tipping 30% for a cab? I don't know about this. And they, in essence, were turned off by that approach. So again, it's these types of things that you think about. They're not always successful. They don't always work. But this is where we kind of think about changing the defaults and the type of impact it may have on our behavior. So now we're going to continue with the SPINE framework, and we're going to talk about phrasing. So one of the big concepts from behavior economics has to do with framing or choice architecture. So I want you to imagine that half the people in this room and online are seeing picture 1. The other half of you are seeing picture 2. Now let's look at those 2 pictures side by side. So according to behavior economics, those of you who saw picture 2 would, on average, not always, but on average, have a more favorable view of the rose than those of you who saw picture 1, even though those roses are absolutely identical in terms of size, shape, and color. This is the idea that our preferences aren't necessarily fixed. You present an idea one way, you may get a different response than if you present it another way. Classic example within healthcare. You describe a hypothetical medical treatment as having 90% survival. People are more enthusiastic about it than if you describe it as having a 10% mortality, even though those are equivalent statements. Patients are susceptible to that bias. Healthcare providers are susceptible to that bias. So let's talk about some other phrasing examples. In this study, they were trying to figure out how to get clinicians to wash their hands. So one message was this middle control message. Hand hygiene prevents you, meaning the healthcare provider, from catching disease. The message that worked better, hand hygiene prevents patients from catching disease. So the question becomes, why did changing a single word make a difference? Well, healthcare providers may think, I'm exposed to so much infectious disease over the years, my immune system is strong, I'm not likely to catch something. But when they viewed it through the more vulnerable lens of their patients, they may think the patients are more vulnerable. And if they're being nudged to look at this more from a patient perspective than from their own perspective, it might nudge them to actually follow hand hygiene. Sometimes in behavior economics, we use stronger language. So in this study, they were trying to increase the likelihood that prescribers would actually order prophylactic or preventative medicines for somebody who's at high risk for HIV. So in the electronic medical record, this is what the prescriber would see. Is the patient eligible for PrEP? That's the prophylactic HIV medicine. The new frame, would this patient benefit from PrEP? Parentheses, a safe daily pill to reduce HIV risk by approximately 99%. Clearly, the language is nudging them to engage in the desired behavior. Another example, when it comes to using stronger language. Really interesting research has looked about how primary care providers introduced the topic of vaccines to parents. Some of them use a natural opt-in style. So a clinician will say to a parent, What do you want to do about shots today? Other primary care providers use a very different communication style. They just say in very much kind of this announcement, matter-of-fact fashion, hey, we have some shots we need to do today. Now, under either of those situations, parents could agree or disagree to get their kids vaccinated. But what was found, if you actually use that opt-out approach, you can increase HPV vaccination rates among younger adolescents, with the idea that these vaccines have been shown to reduce genital warts and maybe even cancer decades down the road. So some people may say, well, maybe that's not the most friendly way to introduce something like this is something we really need to do. I guess I would say a couple things about that. When they did a follow-up about this communication style, a lot of patients actually liked this style because they figured, you know what, you're signaling to me how important and safe these vaccines are. And I'm also going to suggest to you that routine primary care is already very presumptive. So you go to a primary care appointment, I don't think you're going to hear a question like, what do you want to do about having your blood pressure taken today? What do you want to do about somebody listening to your heart? What do you want to do about somebody taking your weight? These are just things that are presumed that happen that somebody can, of course, turn down if they don't want to have happen. So maybe for something like vaccines, where the benefits really outweigh the harm, this type of presumptive approach is worthwhile. Similar examples. This had to do with trying to increase HIV testing rates in the emergency department. So they tested 3 communication styles: opt-in, active choice, opt-out. So the opt-in approach is where you tell a patient who is at high risk for HIV this statement: you can let me, your nurse, or your doctor know if you like a test today. Active choice. This doesn't mean somebody was forced to get tested, but they did need to make a choice. They needed to say yay or nay if they wanted this to happen. So this question would be, would you like to be tested today? The approach that worked best was the opt-out. You will be tested today unless you decline. So let me give an example outside of healthcare. Let's say that we're talking about potentially using this in an industrial setting, and we're trying to encourage somebody to use a new piece of safety equipment, or a piece of safety equipment that is really consistent with best ergonomic principles. So you could think about 3 different ways that a supervisor might introduce that to a team member. The opt-in approach. You can let me know if you'd like to try this safety equipment. The active choice approach. Would you like to try this safety equipment? The opt-out approach. Let's try this piece of safety equipment for a few weeks. So the idea is that even though under either of those situations, you still have freedom, it's not a mandate, but just sometimes these subtle changes in terms of how you present information can really make a difference. Now, one of the things that people will say when I give these examples is they'll say, well, you're talking about nudging. Is nudging just a euphemism for using stronger language? Do you really mean pushing or shoving? And what I'm going to say to you is, no, I mean nudging, because sometimes nudging involves softer language. A couple examples from a couple children's hospital in our state. So this first one comes from Cincinnati Children's. So what they were trying to do at Cincinnati Children's is they were trying to increase the likelihood that clinicians would report their diagnostic mistakes to the larger organization. Now you can imagine if you're a healthcare provider, bring up your hand and go, yep, I made a diagnostic mistake. I kind of blew it on this patient. Not something that people are easily likely to do, right? So what did they do? They softened the language. As opposed to calling them diagnostic errors, they softened it to diagnostic learning opportunities. And that actually led to a demonstrable improvement. Now, the way it works at Nationwide Children's, probably our biggest rival in our world is Cincinnati Children's. Just like OSU probably thinks a lot about that school up north. So whenever I present a Cincinnati Children's example, almost by definition, I got to present a Nationwide Children's example, right? So this second example comes from Nationwide Children's, and I was actually part of this study. So in this study, they were trying to increase the likelihood that members of the anesthesia team would report an adverse event. So this is where something bad or unexpected is happening within the operating room environment. The idea being that if they actually report this to the larger organization, it gives the organization an opportunity to learn to try to prevent this from happening again. So one of the things that was associated with improvement was, again, softening the language. So as opposed to calling it an adverse event, it was changed to a notable event. One of the things I want to encourage you to think about is don't automatically assume people are phrasing things in the best way possible. So I do want to talk about this research study of mine. One of my interests has to do with promoting organ donor registration in the United States. And as you probably well know, most of the time, people agree to be organ donors upon their death when they're interacting with the Department of Motor Vehicles, either through getting a driver's license or a state ID card. What's really interesting about organ donation, this is probably one of the few topics in the United States that has a 95% approval rating. People really approve upon this, but only about 60% of adults are registered donors. And maybe part of this has to do with the way that this is presented, or maybe when they're presented in this opportunity, people are naturally not necessarily in their best mood when interacting with the Bureau of Motor Vehicles, right? So how do we help DMVs do this in the best possible way? We actually can take some lessons from the United Kingdom. So this is with a mega study. And what a mega study refers to is where you have multiple experimental conditions involving large sample sizes, often tens of thousands, if not even larger numbers of participants. So in this particular mega study, they reached out to 1 million United Kingdom citizens as they were renewing their annual vehicle registration. And they tested out 8 different behavioral messages. Everybody got this message. Please join the NHS, National Health Service, Organ Donor Register. But one message rose to the top, and it was based upon the idea of reciprocity. So this is one of my favorite tasks in behavior economics. This is called the ultimatum game. So let me explain how this works. You have an experimenter and you have 2 participants. The experimenter says to participant number 1, here are 10 $1 bills. You get to decide how many of these 10 $1 bills you want to keep for yourself, and you get to offer the remaining amount to the second person. But here's the deal for the second person. You can either accept that deal, in which case both parties walk away with their relative shares, or you can reject the deal, in which case both parties walk away with nothing. So according to standard economics, not behavioral economics, standard economics, the first person should think, okay, I'm going to keep 9 of these dollar bills for myself. I'm going to offer the second person just 1 bill. And the second person, you're not going to turn that down. Who's going to turn down free money? But almost always the second person turns that deal down, even though literally they're turning down free money. Why is that? Because the second person doesn't perceive this as fair. We very much care about fairness. So how did they operationalize this in the UK study? This is the message they used to try to encourage people to join the registry. If you needed an organ transplant, would you have one? If so, please help others. So it's the idea that if I become sick someday, would I be willing to accept an organ donation from a deceased donor? And chances are overwhelming I would. So if I'm going to be fair, should I allow my organs to be used if they're going to be viable someday when I die? So the question becomes, does this actually happen at all in the United States? Are they using evidence-based medicines on driver's license applications? So I was able, with different connections and different techniques, to get a hold of 46 different driver license applications. So people actually will kind of look at this and go, wow, you know, I'm not sure I even want to go to the DMV to do things. This guy is studying the process in detail. So I was actually able to do this, and with a team that I led at Nationwide Children's, this is what we actually found. We didn't find one single state in the United States that used this reciprocity approach, even though it works best in the UK, and even though the whole idea of reciprocity has support from other areas of behavior economics. We couldn't find one state that had a loss frame approach. This is also an evidence-based approach. So this is where you simply highlight to somebody, hey, in our state, each day a certain number of people die waiting for an organ donation. That also is an evidence-based approach to nudge people to join the registry. We could only find about a quarter of the states that had any type of nudge. So these were nudges that were actually based upon social approval. So you actually looked at a driver's license application and you'd see little heart-shaped icons on the organ donation section to try to nudge you to do this. Or maybe it would have language like, our state supports the life-saving and life-enhancing aspects of organ donation. So again, when I kind of think about this study, it suggests there's lots of opportunities maybe to do more effective when it comes to this important topic. All right, spine framework continues, and now we're in the middle when it comes to images. So in this situation, they were trying to decrease errors made when dispensing medication. So this was done at adult hospital system in California. And this was done in the days before barcode scanning was so common. So what they did is they had nurses wear orange vests when dispensing medication on an inpatient unit. The idea was that if nurses were wearing these orange vests, this was supposed to be a strong signal to them they needed to pay very careful attention to this task. Nurses hated this. They found it tacky, even demeaning. Other members of the healthcare team hated this because the deal was when orange were wearing these, they were in their orange vests, these professionals were not to be disturbed. You had to wait to your comments and questions until later. So a lot of people hated it, but when they looked at the actual results, it was successful. It actually got rolled out on more units. One of my other favorite examples. This actually had to do with a university setting. So they were trying to figure out how can we decrease the likelihood that students will litter in a university cafeteria. And they had posters up on the wall. Some of the posters contained something like standard environmental images, something like beautiful flowers. But the image that worked better was an eye image, not the image of an entire face, just the image of a couple of eyes. Seeing a couple of eyes may appeal to our conscience, to our desire to do the right thing. Now, my suggestion to you that all over the place, we need to use orange vests and eye images? No. But am I going to suggest to you there are opportunities to use visual images more successfully to nudge people? That is what I'm suggesting you to think about. So let me give a couple more examples. In this study, again, published in JAMA Surgery, because I think it's very straightforward that other healthcare facilities can replicate. They were trying to decrease the likelihood that for certain older women, based upon demographic and clinical characteristics, certain older women do not require their lymph nodes to be biopsied as part of a breast cancer surgery procedure. But as much as they were educating the surgeons about this, they needed to figure out a more effective nudge. So basically what would happen when the surgeons saw on their schedule in the electronic medical record about their patients they'd be operating on that day, for those patients who did not require that lymph node biopsy, they would see this image in one of the columns. So basically a little clipboard image with a little red X to the side, nudging them not to do this. And again, this was a successful intervention. And I guess part of me would think that maybe the pictures were part of it, right? There's this idea called the picture superiority effect, that sometimes we are more likely to remember pictures than we are other types of things. And particularly in the electronic medical record, it's very dense with words. They don't use images very often. Number 4 for image is something called kindergarten font. So this was actually something that we did some work on at Nationwide Children's. So kindergarten font actually is with an older example of PowerPoint that looks like it's being used or written by a kindergartner. And the way I actually came up with this idea, I have family in Indiana, and a few years ago, I was driving back to Indiana through a construction zone. And I encountered 2 signs. One side read, "My mommy works here," and the other sign said, "My daddy works here." And they were actually written in kindergarten font as opposed to more standard font, right? And that was really attention grabbing to me. And again, that's exactly what they wanted to do. They wanted me to get the sense that when I was driving in this zone, I'm not just going past, workers, I'm also going past parents. And I need to remember that they've got kids and I need to be very careful and slow down and do the right thing in these construction zones. But the other thing that this message does, it has to do with the next part of the SPINE framework, and that has to do with norms. So sometimes just learning about what others are doing can nudge us in the right direction. Social influences are powerful. So one of my favorite studies has to do with hotel towels. So they were trying to figure out, if you have somebody staying in a hotel room, how can you encourage them to reuse their towels if they're staying more than one night? To hang up the towels over the shower rod in the bathroom, indicating to housekeeping that they don't want fresh linens each and every day. And you may have actually seen messages in hotel bathrooms that will say, if you reuse your towels, it's good for the environment. It saves on hot water, electricity, detergent. As it turns out, that's not the most effective way to get people to reuse their towels. If you add the information, many previous hotel guests reuse their towels, that works better. And if you change it to many previous hotel guests who've stayed in your exact same hotel room before reuse their towels. When we learn what other people are doing, it may convince us that the desired behavior is feasible, acceptable, and important, particularly if those other people are viewed as having some similarity to us. So there may be situations where these norms work because people are simply unaware of the desired behavior engaged by many other similar individuals. So if I stay in a hotel room, I have no idea what the history is of that hotel room. I don't know if other guests have reused their towels or not. So that potentially could be novel information that could nudge me in the right direction. And the other thing to think about when it comes to norms is you don't have to say to somebody, nearly everybody else is doing this. Maybe you should think about doing this as well. One of the overall lessons from BE is, so long as you're able to say many other people are doing this, you should consider this as well. That may be enough of a nudge. And again, that's really important because when it comes to a lot of target behaviors, we can't necessarily say 99.9% of people are doing this, you should do this as well. We can only really say that many others are doing this. So how is this relevant when it comes to healthcare provider behavior? So we want healthcare providers, when they're prescribing medication, particularly things like opioids, antipsychotic, antibiotics, to prescribe them only when necessary. And unfortunately, in the United States, there are examples where people are overprescribing these medications. So these are a series of studies that use this type of peer comparison approach, where basically what would happen is high prescribers, those that maybe were not being as judicious in their prescribing as they needed to be, they would get periodic feedback reports that they were a high prescriber relative to their peers. And just getting that information in and of itself was enough to nudge them to maybe cut back a little bit on the prescribing and be more judicious. One other thing I'll say when it comes to norms, I think it's really important that we just don't think about highlighting the desired behavior of certain people, but we also want to highlight the professionals and the people that people trust the most. So in the United States, pediatric practices vary in terms of who can give vaccines. So about 36% of pediatricians have standing orders for vaccines. Another 23% have standing orders for some vaccines. Let me be clear what a standing order means. That means that another member of the healthcare team, besides the physician, has the authority to screen for interest and eligibility and give the shot without even consulting with the physician. Standing orders are used all the time within healthcare practices, even if we don't realize it, right? Every time you go to a healthcare practice and you complete a survey or get your vitals checked, it's not like there's a healthcare provider each and every time who's pushing a button agreeing for that to happen, right? So practically what this means is nurses and pharmacists are having more roles in this process. And as I was talking about before, one of my interests is in vaccinations. Nurses having more of a role in this is probably really good for multiple reasons. One, physicians can be very busy, but according to the Gallup organization, for the last 25 years in a row, nurses are the most trusted professionals in the United States according to the general public. Physicians are in the top tier, pharmacists are in the top tier, but nurses have been number one for 25 years in a row, suggesting particularly in this day and age when there's probably more concern or hesitancy about vaccinations, are there opportunities to use more of these professionals? So let's wrap up the SPINE framework with employee input. And the idea that comes from behavior economics, and it's certainly not specific to the field of behavior economics, is something called the IKEA effect. And this refers to IKEA furniture stores. So for those of you who are not familiar with IKEA furniture stores, this is the idea that you get furniture that's not been 100% pre-assembled. You have to take the final steps to assemble it yourself. And this is actually a very successful business model. Some people really like doing this, and they will go back and back and back to IKEA furniture stores for this opportunity. Even if they're only having a relatively small part of the effort to make the furniture, they have this sense of ownership, like they really value their contribution. So what the IKEA effect refers to more globally in behavior economics is that people very much value their input to an overall effort, right? If you look at an overall project and you ask all the contributors, what percent of that project's success was attributed to you, and you have them to, in essence, do this privately, kind of total those percentages, that percentage would go way above 100%, right? So this is very much the idea that basically when you're coming up with different initiatives to try to make sure that you're getting employees' input on this, even if they're making relatively modest contributions, that can be enough because they can really value those contributions, be more likely to get you on board with that initiative. So as I wrap up with this, I do want to give one example that I was able to find recently, and this was actually published this month in a journal called Journal of Loss Prevention in the Process Industries. So I want to give an example of nudges in an industrial setting. So I'm going to give a quote, and I'm going to give the specific example. So here's the quote that comes from those authors. Unlike traditional approaches that often rely on rules, regulations, and punitive measures, the nudging interventions focus on gently guiding individuals towards safer choices through subtle changes in the physical, social, or informational decision context. And again, that probably gives you a little sense of some of the things I've talked about already with this SPINE framework. So what exactly did they do in this study that was just published this month? They were trying to nudge employees to be very careful around certain things in an industrial setting that would be potentially dangerous. particularly heavy suspended loads and dangerous machinery. So they tested a series of nudges. So the first nudge had to do with descriptive norms. So basically, when employees were following a safe pathway that was way outside of the range of a suspended load, there would be an automated digital counter that would actually count that instance and would actually provide feedback to people so that basically when you were walking by that area, other employees could see that lots of other employees were using that walking pathway. So that was one nudge. Second nudge had to do with simplification. So in this situation, they basically changed the placement of optimal equipment that enabled somebody to not directly touch a dangerous piece of equipment. So basically the way they kind of phrased it was no touch tools. So basically if there's a dangerous piece of equipment, it's much better for somebody to use that no touch tool than directly put their hand in it or near it, right? And they're trying to nudge people to use those no touch tools. And basically they just made it so it was easier to get access to those no touch tools as opposed to having to walk several feet to get them. Nudge number 3, visual images. So in terms of these suspended loads, they made it much clearer where those suspended loads were in a busy industrial setting by strategically placing lighting underneath those loads so that if you were walking around and seeing what was going on, you're like, wow, that looks a little bit different. So you're more likely to pay attention to that. So these are some of the examples that I was able to find of how this has been applied within an industrial setting. And all 3 of these were successful nudges. So let's have some take-home messages and then we'll open this up for some comments and questions. So the first take-home message is, why nudge? Education is often insufficient to change behavior. So this becomes a tough message, particularly at a teaching hospital like Nationwide Children's. Because again, we pride ourselves in lectures and simulation and teaching and all that. And again, it's not that those are bad things, those are great things. But often you need other levers of change if you're going to maximize healthcare provider performance. Second point, nudging often has a favorable benefit cost trade-off. So I don't want to suggest to you that the type of strategies I talked about today are panaceas. They're not always going to work. But what they often would do will produce a big bang for the buck, in essence. So in this article entitled, Should Governments Invest More in Nudging? They compare the type of strategies I talked about today with more resource-intensive strategies. So things like big financial incentive programs or comprehensive education programs. And what they found, again, nudging was not a panacea, but in many different areas, nudging had a very favorable benefit-cost trade-off. And of course, we have to ask ourselves, under what situations is it ethical to nudge anybody to do anything? Just because you can nudge doesn't mean you should nudge. So about 100 years ago, there was an economist by the name of John Maynard Keynes. He is attributed as saying the following: in the long run, we're all dead. He was not concerned about our physical health. He was concerned about economic depressions. There was an idea in the United States at the time that if an economy was in a depression, government should not intervene. And Keynes came along and said, of course government should intervene. They should do things like tax cuts, stimulus spending programs, so a depression doesn't last as long and is not as severe. I'm going to suggest to you that there are situations where I think it's actually ethical to nudge. One of my favorite examples that I'm obviously a bit biased for has to do with vaccinations. I think if you look at the benefit cost trade-off of a vaccine, they tend to be very beneficial both to the patients and often to other people who aren't even vaccinated. So I think that's a nudge-worthy situation. I bet you can think of others. Take-home message number 2, whom and when to nudge. People who are adamantly against a particular behavior aren't going to respond to the type of strategies I talked about today. But there are 2 groups of people who might actually benefit. If you have somebody who's ambivalent about a behavior, trying to get them to do something and they don't really have strong feelings one way or another whether or not they want to do it, nudging may be useful. And if you have somebody who's really interested in the behavior, but they're just busy and distracted, they're attending to lots of other things, that also may be a group where nudging would be appropriate. And finally, I want to give you this take-home message. I'm going to suggest to you that evidence-based medicine should be more than evidence-based medicines. So there's so much emphasis when it comes to healthcare on evidence-based medicine, the idea that we're going to use scientifically based, carefully studied approaches when it comes to delivering care to patients, which is great. But so much of that emphasis has to do on trying to figure out whether or not the medication is appropriate. And that's really important. I'm not saying that shouldn't be done. But we should also think about what are some of the behavioral strategies that are used, both on the patient and the clinician side, to maximize healthcare outcomes. And I know as a psychologist, I'm going to sound really biased emphasizing this, but I also want to highlight this interesting fact for your consideration. 10 years ago, the medical college admission test added a new section entitled Psychological, Social, Biological Foundations of Behavior. So for decades, aspiring physicians had to have expertise in chemistry, biology, physics. But just 10 years ago, they added this new section, suggesting that even within the healthcare field, there's more growing realization that the behavioral and social sciences really matter. So let me end with this. Often when I do these types of presentations on behavioral economics, people kind of take away some of the messages and they'll kind of think about this a bit. But if there's real interest potentially in more collaboration or thinking about how they're relevant for your purposes, often what I find is follow-up discussions are needed. This isn't just kind of a one-shot deal where you get exposed to BE. Often you have to have a series of follow-up conversations where I learn more about your priorities. I offer some ideas for your consideration about how they might be adopted for the types of things that you want to accomplish. So that's one thing I ask that you think about. But if you think about, are there opportunities for me to be involved in any projects that you're doing, whether or not it's with an industrial partner, whether it has to do with federal funding, things of that nature, I think it's also really important to think about what might be the optimal way to frame even me, right? So let me talk about a couple different frames. So one way to frame me potentially is if you're going to say what my current institution is, you could say I work for Ohio State University, which is true. My guess would be for certain federal and industrial partners, that's going to be better received than saying I work for Nationwide Children's Hospital, even though I work for both institutions. If you were going to say, okay, what's this guy's background in terms of my past training? My undergraduate's from the Wharton School of Business. For some partners, that may be a better frame than saying I did a postdoctoral fellowship at Cincinnati Children's. And finally, if you're going to say, what kind of projects does this person work on? I do a lot of projects that involve hospital workers. So how do we encourage them to optimize their performance? What may be less convincing for other partners is that there's also a part of my portfolio where I focus very much on families. So for example, how do I encourage patients to take medication more consistently? So again, it's not like you frame me one way versus another way and all of a sudden I can completely shut off another part of who I am. But again, it's the idea that even with somebody who does different types of things, there may be one better way to present information than with something else. So with that, I thank you so much for your time and attention. I really appreciate the opportunity to be here. I very much appreciate the people who are online as well. And I'd be happy to take any comments or questions that you have this afternoon.
Mike. So we think about that.
Well, first off, thank you very much, Jack. That was very, very interesting and very informative. Even though I know you're not all about education. So I've sat on a lot of committees in the medical center where they do things like rate physician satisfaction, like in different specialties, like I'm familiar with the spine, and they say physician one has a 90% satisfaction rating where this other guy has a 50, and they basically send that around to all the physicians in that particular group. I imagine that is kind of a nudge to get the people at the bottom to see what they're doing at the top. And the interesting thing is, it's got nothing to do with healthcare. It's just got to do with how happy are the patients.
Absolutely. So again, like that is a common intervention that's used. And, you know, when I think about some of the things that have been done really well with that bill, is that where it goes beyond something like satisfaction to a harder outcome. So for example, patient mortality. So one of my favorite examples actually had to do with some work that was done in New York State, where they actually gave cardiac surgeons feedback about how their mortality rate compared to their peers. And as you can imagine, the first thing that came out of their mouths was, my patients are sicker. Of course, you know, I'm lower performing. I have patients sicker. So they had to do some risk adjustment to try to account for that. But once they did some risk adjustment with all that, they actually found that this was an effective intervention. It didn't lead to a huge decrease, but it leads to at least a little bit of a decrease in mortality, suggesting that getting this information can actually have some more tangible benefit that goes beyond just something like satisfaction. I think when it comes down to it, when it comes to the whole social norms approach, there's probably some different reasons why that may have some benefit, right? First of all, you learn what others are doing. You may say, well, if somebody else is doing that, maybe it's important and feasible and acceptable for me to do that as well. But there may be a different mechanism as well. So you could imagine, particularly for surgeons, but for lots of other professions as well, that they tend to be very competitive individuals. So if they find out that maybe they're not performing as well as some of their peers, that can also be a nudge to consider them to actually improve their performance.
Well, somewhat related to this past weekend, I spent some time with some friends, and one of them had some orthopedic surgery. And, so I asked him about it, and he said, well, yeah, I went and saw my doctor, and he said, on the follow-up visit, and he said the first thing out of the surgeon's mouth was, I did a great job on you. What a successful surgery. And this guy could barely walk. I mean, he was hobbling all over the place. What kind of a nudge are we talking about here?
Again, this is the hard part, right? Because, the real question becomes, what performance metric should we actually set, right? Like, is the performance metric solely going to be kind of the physician's anecdotal or qualitative impression about how they did? And my guess would be, particularly for the type of intervention you're talking about, don't we really want a metric that probably would be a bit more objective? So for example, how is the patient functioning and walking a month later or 2 months later, whatever the benchmark may be, right? And I think really when we're talking about nudging, those are the types of things that I think the literature is starting to really focus on, right? Like, where are some things that are really worthwhile from a healthcare provider's perspective to get feedback on? And so like the examples I gave on that slide about tens of millions of times in the United States, somebody's prescribed an antibiotic for a viral condition, they don't need it. And there's too much prescribing of opioids and antipsychotics just to try to feel like you're either sedating somebody or giving them pain relief when that isn't necessarily needed, right? So I think a lot of it also comes back to just trying to find out when that performance metric is really appropriate, and knowing that not everybody's going to respond to that feedback, right? Because there are some people, a lot of us will go, hey, I want to do it just as well as my peers, or I want to learn from my peers. But there are some people who actually have the opposite approach, where they have more of the cowboy or the cowgirl mentality that says, you know what, if somebody else is doing this, I want to run and do the opposite kind of thing, right? So again, there's all these kind of contextual factors that probably also influence whether or not that type of peer comparison nudge would be useful.
Well, what I was wondering is, was that physician telling him that so he could nudge him towards better patient satisfaction? Or was he trying to nudge him towards suck it up, you'll be fine, don't adopt this pain behavior, just, start walking around.
Great question, right? It could have been for that, or it could have been just setting the expectation. Your surgery went really well, and because the surgery went well, we know there's an expectation bias. You set a positive expectation for somebody, and often that in and of itself will lead to a better outcome. So it may not just be purely kind of egotistical, if you will, on part of the surgeon. There may be an actual rationale for doing that as well. But again, it also then comes back to the idea of just because you can nudge, should you nudge, and all that.
I had a question. With this nudging, is there kind of a fatigue effect where it might work well initially because it's novel, but then as people get used to it over time, the adoption goes down and you almost need to refresh it from time to time just to keep it fresh in their minds?
Fantastic question, absolutely as well. So this is where, again, the field is relatively new. I wish I could give you a more definitive answer to that type of situation. My gut would tell me is you probably need to refresh every so often for a lot of situations. But I will give a caveat with that I can think of at least one or two situations where if you nudge initially and you can kind of get people over the hump and they get used to doing something over and over again, it becomes part of their routinized practice and you don't have to keep nudging them again, right? So the classic example that I can think of has to do with one of the studies I mentioned on there about trying to give people feedback that they are high prescribers of antibiotics relative to their peers. So that peer comparison intervention. So they would give this type of feedback maybe for like a year or so. And then they stop giving those peer comparison reports. And what they found is that for those people who were assigned to that peer comparison condition, they continued to be judicious prescribers in all this. But again, I don't want to say that always applies under all circumstances. This is one of the things we need to learn. We need to learn when can you use one nudge and it's going to have this enduring effect? When can you use one nudge and it's just not going to have a lasting effect? When do you need to use a series of nudges? But these are just some of the things we need to have a better understanding for in the world. But certainly your concern you mentioned is quite valid. Other comments and questions, please.
Yeah, question kind of similar to that actually is, do you understand, or does the I guess does the literature call out the effect of like softening the nudge after? I think the ethical question is really interesting. Of obviously, I think this can be used for good or evil by different parties. And so if you're concerned about like, I really think we should nudge them this way, but there is this kind of ethical concern, if you soften it at the end, like I think you should get this vaccine. What do you think? But kind of bring it back to the table as more of a conversation. Number one, is that nudge, does it remain as effective because you've still given them the kind of your thought of which direction they should go, but are you bringing it back more to the table to really give them more decision power and try not to influence them as much?
Again, we need more research on exactly what you're talking about. So the phrase that's used by the Penn Medicine Nudge Unit that I often use with different people I collaborate, is the phrase entitled "dial it up." So what do they mean by that? It's the idea that under some circumstances, you may have to start with a relatively low intensity nudge, see what impact that has, because that may be the most acceptable or palatable thing. And then if you need to, you can use a more intense nudge, and then you have to follow up for a more intense nudge. But again, there may be situations where you need to reverse engineer that, if you will, and go the opposite direction. So again, I wish I could give you a more definitive answer and examples of that, but I think that's a really important question as well, is we need to think about how do we layer the nudges, and do we start off with the most intense and then go down? Do we start with the least intense and go up? At least anecdotally, what they would say at the Penn Medicine Nudge Unit is that what they found to be probably most acceptable is to start with the least intensive, see what that impact is, and then kind of go up to things that are more intensive.
Follow-up question, does this overlap quite a bit with like consumer psychology and kind of influencing consumer behavior?
Absolutely. So part of this undoubtedly comes from some of the ideas that we have when it comes to marketing, for example, and consumer behavior and consumer psychology. And undoubtedly, that can also be part of what this is. I would say that where this may vary just a little bit is that it's probably used for maybe some broader purposes that maybe traditional marketing wouldn't think about. So for example, various public policy objectives or various healthcare objectives. But absolutely, and sometimes when I give the definition of behavioral economics, depending upon the audience and just what I put on a particular slide, I will say this is a field that features insights from economics, psychology, and marketing, because again, part of this is definitely based upon exactly that approach.
Thank you, Dr. Stevens, for a wonderful presentation. So I actually took a course a year ago on judgment and decision making. So in that course, my instructor talked a lot about nudges. And I guess if I remember correctly, he gave us an example and since you also mentioned about the organ donation thing, so in the US, it's still an opt-in style, but in most European countries, it's opt-out. And they have seen that the number of organ donations, it's huge in European countries compared to the US. So my question is that if one nudge is working in one set of demographic condition, is it certain that it's going to work in another demographic condition, or should we, and how do we, make some assumption on that, or how do we change them, or how do we fix them?
Absolutely. Again, it goes back to the context matters, right? The United States is not going to be an opt-out approach when it comes to organ donation. They've done surveys of this. And while some people find that to be acceptable, a lot of people don't. So it almost goes back to the earlier point that was kind of raised as well, right? Is that it really depends upon the audience and the particular people, and really kind of knowing a bit about the audience and testing some of these strategies out and doing some pilot work and things of that nature. Because again, I very much agree that in some of the European countries, opt-out is acceptable, probably would not be acceptable in the United States. But again, I think what's good about a lot of these strategies is it's not just one approach. It's not just like opt-in versus opt-out. Like when I did that, the driver's license application work, I was not assuming an opt-out approach. I was assuming an opt-in approach. But even with the opt-in approach, I was looking for all these different type of messaging that could be used to encourage somebody to kind of opt in and all that. So again, these are things that we still need to do more work on, quite honestly, is to just better able to understand the context, better able to understand when you should use opt-in, when you should use opt-out. And again, the other thing that becomes tough about this, right, why it can't be just a universal, is what one person thinks is a nudge, somebody else may think is a nag, right? So that becomes tough. Like even with like the GPS device I gave example, that's one of my favorite nudges. So I am a volunteer driver with Meals on Wheels. So I use a GPS device. It really helps me. And I would say that it's a good nudge. But if I decide to drive a different route for whatever reason, sometimes it will kind of come back at me and say, turn around, do this, right? So even though I want to give that example as a nudge, if somebody actually heard my GPS device, you'd be like, well, maybe it's a nudge, but maybe it's a nag. But then again, what often will happen is once I reach a certain point where the device figures out, I'm not going to turn around and take this course, it will literally say out loud, switching to an alternative route. So even that kind of has this flavor of like, okay, Jack is not going to take Main Street Road in order to do it. So if he doesn't want to do it, I got to be a little bit more flexible. But can I still kind of nudge him with maybe a second route, even if it's not maybe the preferred first route? So again, these are just really important contextual things. And the field is relatively new, but hopefully as we do more and more work, we're going to be able to have better answers for exactly the important questions all of you will raise. Any other comments or questions? Please.
So if I remember it right, one of the fundamentals was that a nudge shouldn't be forced. But on I think slide 39, does it depend on who is using that nudge? Like if an insurance company start to use that?
So is this the one you're talking about right there?
Yeah.
Okay. So again, so just so we're clear, right? This was only done by nudging these were healthcare administrators who were nudging the prescribers. You're right. It was not an insurance company saying you have to pre-authorize this or things of that nature, right? So that would be another way to change healthcare providers' behavior. You could think of a situation where for maybe prescribing any of these medicines, you actually have to go through a pre-authorization process in order to be able to do that. And that may have some benefit. Technically, that probably wouldn't be considered a nudge because again, some people may still consider a nudge. It depends upon, again, how you kind of frame this, right? One person's nudge is another person's nag. Because at the end of the day, with all these different studies, while the clinicians were getting the feedback, they weren't being forced to prescribe in a particular day. So even like with the opioids, this was done in the days before there were more strict opioid prescribing limits that have been put in place over the last several years. So again, it's a really important thing, but again, in these studies, generally a nudge is going to involve at least a certain degree of freedom and choice, as opposed to somebody saying you absolutely have to do something, right? Does that help answer your question? Glad to do it. And again, thanks for the invitation. If there are opportunities to collaborate, I would welcome. So thanks again.